appreciate all y'all's input and time for today. Just fun to play a video of a persistent air leak. All right, so background, persistent air leak, what does it actually mean? It's completely arbitrary in the literature. It is all over the place. I am telling you, truly, there is no consensus definition, but essentially PAL is defined as an air leak persisting greater than 4 to 7 days. Some literature says 48 hours, some literature says all the way to 7, whatever. 4 to 7 seems to be the consensus kind of what most people say. It can either be caused by an alveolar pleural fistula or a bronchopleural fistula. It most commonly occurs in the postoperative setting, lung volume reduction surgery, lung resection, biopsy, or specifically like VATS biopsy or open biopsy. But it can also be seen in primary spontaneous pneumothoraces and secondary spontaneous pneumothoraces, with SSP obviously being the more common to have a PAL due to the underlying lung disruption. But can also be seen in the setting of chest trauma, barotrauma, or in the setting of mechanical ventilation, malignancy if extensive or involving the major airways, and necrotizing lung infections. It has a very high morbidity and classically has been associated with a high mortality. We'll talk a little bit about that in a second. But definitely results in longer chest tube duration, definitely results in increased length of stays, and definitely, like clearly, right, increased resource utilization. This picture on the right is just included to show you that up until 2001, or after 2001 and until BTS 2010, this was the only paragraph about persistent air leak in the entirety of any major organization's guidelines. ACCP released their spontaneous pneumo guidelines in 2001. This is what that picture is there. Other than that, there was nothing else about it. There's never been a dedicated PAL guideline. BTS 2010 and 2023 said some things about it, and then ERS in 2024 really is the first guideline document that has any PICO questions related to persistent air leak, is in 2024. ATS, AATS, STS have never published guidelines on this topic. And if you guys saw in my chat in the chat the other day, I asked if anyone had access to the CHEST videos. They had a preview session at CHEST 2025, but they're planning to release updated guidelines next year. So what's the incidence of this? Lung volume reduction surgery is the most common, 24 to 46% of patients who have lung volume reduction surgery can develop a persistent air leak. Lobectomy happens at about 5.6 to 26%, huge range there, right? Like, and some of these studies that some of the higher numbers are from are older. Wedge resection seems to be less likely of the surgical modalities. Not a lot of data about PAL in pneumothoraces, but in primary spontaneous pneumo, one small series reported, it was like less than 100 people, reported an incidence of 20.6%, versus in SSP, it's higher in the 30s somewhere. But again, very, very limited data. There's no real data on post-bronchoscopic lung volume reduction that I could find in terms of how frequently, but what's the common theme here? It varies. And because the definitions of PAL are heterogeneous, what does this actually even mean in terms of incidence? It can happen is, I think, what you can take. And surgical is definitely more common than the others. Risk factors. So there have been quite a few, because the thoracic societies, really like to choose their patients wisely before they take someone to surgery. There have been quite a few reviews on risk factors for the development of PAL, COPD, female sex, lower FEV1, smoking, active smoking status, diabetes, or chronic steroid use and lobectomy leads to increased risk of PAL. In lung volume reduction surgery, having bad lungs or bad PFTs with a lot of adhesions or diffuse or upper lobe emphysema, increased risk. In the setting of pneumothorax, definitely the underlying lung disease. As you get older, there's an increased risk, and the larger bullas are at more risk. Again, what's the common theme here? Bad lungs, more likely to get a PAL. Morbidity-wise, it increases pulmonary complications, emphysema formation, need for additional chest tubes, need for return to the OR, increased hospital length of stay, and increased 30-day admission rate. And you can see the odds ratios all there. It on average increases the length of hospital stay by 5 days over someone who does not develop a PAL. Mortality. So honestly, the older studies really showed a huge range of mortality. I mean, there's one from like, I think it was 98 that was in a trauma hospital, and they showed a mortality of like up to 60%, but they were using a tidal volume of 14 mils per kg. So the 2021 study, though, showed no increased 30-day mortality after propensity weighting. So I think we need more information on mortality. But in my opinion, if something increases morbidity, it's probably also increasing mortality. So how do we make this diagnosis? It's mainly a diagnosis of objective monitoring. Hallmark is persistent bubbling within the water seal chamber of the chest tube atrium. You may see re-expansion of the pneumothorax when placed on water seal or even while on continuous suction, like our patient here. And subcutaneous emphysema may be out of proportion to typical findings. And if severe, can progress to the point of causing organ dysfunction, like in our patient. If mechanically ventilated, you may see a pretty significant variation between inspiratory tidal volumes and expiratory tidal volumes due to the leak. And you may actually have difficulty achieving adequate ventilation, and it can theoretically cause hypercapnia. There's a little bit of variability in the literature of whether you would actually have, one source I saw said that you can develop an alkalosis due to the leak. Honestly, I think if you have difficulty achieving adequate ventilation, it's going to cause hypercapnia. I think a loss of CO2 through an air leak, I don't know that it would cause a hypocapnia. So how do we quantify air leak severity? There's this classification called the Serfolio classification, and it goes grade 1 through 4 with a sub classification of like letter-based, FE, E, I, and C, which means forced expiration, expiration only, inspiration only, or continuous. This is an even better demonstration that really helped my brain kind of understand what the letter portions meant of the Serfolio classification. But essentially, grade 1, forced expiration only, commonly done through coughing, expiration only, inspiration only, and then continuous. And the chamber, in theory, helps you grade what the severity of the air leak is. But this, I mean, it's pretty like low tech, right? They've actually come out with some digital monitors now for air leak quantification. And some studies are looking at does air leak determine, can they predict how long someone will have a chest tube, that initial air leak. A quick dive. So 2001, first guidelines released, right? And they say that air leaks persisting beyond 4 days should be evaluated for surgical closure of the air leak and pleurodesis. They say mechanical pleurodesis is preferred. Chemical pleurodesis should not be used unless contraindications to surgery. And if you are going to do chemical, you use doxy or talc. Back in 2001, they actually say should not undergo additional chest tube or bronchoscopy. We'll see how that changes with time.
So I guess the tricky stuff is you chemically pleurodesmin, but that doesn't work. The surgeon, he has to go to surgery, but in touch like that, it becomes very nasty, very bloody, becomes a higher risk of complications from that. So you absolutely have to get the surgeon to tell you, I can, he's 100 years old.
Yeah.
And then the question is, I guess you're hoping that that thing is expanded enough with a persistent leak, right?
Bingo. Honestly, I think they were very clear, right? Should not be used unless you're stuck in a corner. They do here say they select VATS as the preferred management, but they acknowledge that there's really no data at this time in 2001. So we move on to 2010, and BTS comes out and says, persistent air leak with or without incomplete re-expansion is the usual reason for consideration of the use of suction. There's no evidence, is what they say at this point. Conservative management may be appropriate because 100% of PSP with a persistent air leak greater than 7 days will resolve by 14. And 79% of those with secondary will resolve by 14 days with no mortality in either group. So now they're saying, wait, what are we talking about 4 days? If you can keep it in for 14, will it go away? And then they say, but you should consider early thoracic surgery at 3 to 5 days. But then they also say in SSP, 48 hours. These are all over the place. How does this help us at all? I mean, I don't think this one helped literally any. That's as comparable to open thoracotomy.
I think what you get from here is that there's even less value in chemical fluorodesis.
I agree.
And if you have a great patient taking for surgery,
Yep.
you know, got a 25-year-old who plays basketball, but you have the 100-year-old put a Hamlet valve that's chemically pure.
Yes, I agree with you completely. I think that's exactly what this says. They said we have no idea what's going on outside of, we know surgery is better. And if you can't do surgery, find something else. 2023, they again say no evidence to suggest that the application of suction is beneficial to treat pneumothorax and persistent air leaks in adults. They do say, though, on a case-by-case basis, thoracic suction may be considered. Again, no robust data, but they advise that you use a max of negative 20 centimeters of water. They say thoracic surgery is often the treatment of choice for ongoing air leak. But again, there's no evidence on when to base the ideal timing, is what they say here. They actually,
their previous ones, they didn't have any recommendations, so everyone was all over the place.
yeah. And then they go on to say, we don't know if VATS or thoracotomy is better now, but we do know VATS leads to a shorter length of hospital stay, less pain, and less complication. They say if a patient is not considered fit for surgery now in 2023, that autologous blood pleurodesis or endobronchial therapy should be considered. But they say the evidence is so limited. The only evidence they could find is that length of stay was shorter with ABP here. And the only endobronchial evidence, they just say limited. They don't, it's like one prospective non-randomized trial. It may have the potential to treat. They say, and this is where what you're talking about comes in. Now they're saying, hey, look, if you have a persistent air leak with poor lung expansion and the patient can't go to surgery, you should really consider the idea of a Heimlich valve. And then there is insufficient evidence to make any recommendations on the best treatment method for pneumothorax and persistent air leak in adults. So in comes the best guideline we've had to date, the 2024 ERS. And this is the first guideline that had specific PICO questions about PAL. And it also, every single section, they say what we need to do going forward to find out more evidence. I didn't talk about that part, but so suction, they say no recommendation to advise for or against suction in patients with PSP or in patients with SSP due to lack of conclusive evidence. Autologous blood products or autologous blood pleurodesis, however you want to go call it. Some people call it ABP, some people call it ABPP, but no recommendation in PSP, but can be considered in SSP who are not fit for surgery. They go later down in their supplemental section of the narrative questions to say, we think the evidence supports a dose of 1 to 2 mLs per kg if you're going to do it. So what do they say about valves? No recommendation for or against bronchial valves in patients with PSP or in patients who are SSP who are not fit for surgery due to lack of evidence. And then in surgery, what do they say? We don't know the ideal approach. When considering surgery in SSP with persistent air leak, we should consider the following factors: age, comorbidities, type of underlying lung disease, performance status, ASA score, and degree of emphysema on CT. And they go on to further clarify what they mean by that. They say if you have a patient with a large air leak with non-expandable lung, that's probably going to need early intervention compared to someone who has an expanded lung that if they're high risk, maybe you consider chemical pleurodesis. So on to now we're moving past guidelines into some studies about these advanced therapies because I mean, as you guys saw here, the basic therapies didn't help our patient, right? Just leaving the chest tube in, it kept getting worse. So we had to do something else. I mean, this guy's sick. So what does autologous blood patch or autologous blood patch pleurodesis have to say? So the theory, right? If you do it intrapleurally, it coats the defect, or if you do it intrabronchially, it coats the defect as well. So via indwelling chest tube, what do? You get a fresh venous sample from a peripheral access site, instill it via the indwelling chest tube, and clamp for 30 to 120 minutes. ERS says 1 to 2 mLs per kg, but Mayo has their own protocol and says 1 to 3 mLs per kg. Mayo is really the leader in this and bronchoscopic PAL management. Bronchoscopic approach, which if you guys, I mean, when I first read this, I was like, holy cow, this is crazy. But clearly people do it. They actually put a Swan-Ganz through the bronch after identifying the segment that they believe is causing the leak, and then instill the blood through the Swan-Ganz. Zhang et al. Had
Is it in the inner canal or it goes on the side next to it? I mean, whatever. That's
Zhang et al. Put it through the therapeutic channel of a therapeutic scope.
This is just pretty much any catheter that you could instill beds through that has a balloon on the end to wedge and tamponade.
Yeah. Because you wanted to go where you wanted to go, right? Zhang et al. Protocol, which is really the only protocol kind of really available. They did 20 to 30 mLs of the ABP with 3 mLs of thrombin, or 3,000 units of thrombin.
So, I mean, this is like not an insignificant amount of blood they're taking. It's like 150 200 cc's of blood having to take. So you
And I didn't include it there, but most of the organizations recommend doing it on day 0, whatever day 0 you define, day 2 and day 4. So you do it 3 times for the intrapleural approach. So what's the evidence? There's really 3 major RCTs, one in UK, one in Egypt, one in China. Basically all they've shown, air leak duration is shorter with ABP, time to chest tube removal and length of stay were shorter. The strongest one to date is Zhang et al. In 2019 out of China, who had a 3-arm multi-center trial, 50 people, chest tube drainage alone, 50 into bronchial blood patch, and 50 with what they called occlusion with silicone spigot, which we do in the United States with valves. But in relation to the endobronchial ABP here, they showed air leak was resolved in 82% in the ABP group versus 60% in the chest tube drainage group alone. Shorter length of stay. What's endobronchial valve placement? What's the theory? Find the hole and plug it. How do you find the hole? 3 options: direct visualization, balloon occlusion, or dye installation. For direct visualization, mostly for proximal bronchial pleural fistulas or major stump anastomotic dehiscence. Balloon occlusion, what do? You slide a Fogarty catheter through the bronchoscope or around the bronchoscope, and you occlude in a serial kind of sequential manner the airways of either, I mean, if it's on the right side, you start with just the complete upper lobe, and you see, okay, does the air leak stop? Okay, cool. Now let's go find which subsegment of the upper lobe causes it to stop. Sometimes it has to be multiple because of collateral ventilation. But if you don't find it with there, which happens about 25% of the time when you're doing this, about 75% of people can have their leak identified this way. You can do something called dye installation, where you do instill methylene blue intrapleurally through an indwelling chest tube, and then under bronchoscopic evaluation, you watch the egress of the methylene blue into the airways. And then how do they occlude unidirectional endobronchial valve in the segment of choice? And Olympus actually gave their FDA humanitarian device approval for post-surgical persistent air leaks in 2008.
the only trick is, I don't know what's better, when you want to install that methylene blue, make sure that you disconnect it from the vent for a minute. So the methylene blue can actually go in that direction for either.
Gotcha, that's-
For a second, someone pushes and someone pulls.
Oh, that's super smart, because if you have just positive pressure,
Yeah.
it's not going to come in.
Yeah, especially, it's all very hard when it's a small leak, right?
Yeah.
even try to clamp it on different things, it's very hard to see if it's just like that.
So just so y'all are aware, Zephyr does not actually have approval for this indication, but it's still used. So what's the evidence here? Again, Zhang et al. Is kind of the one leading the way. It was a RCT, 84% in the occlusion group had resolution versus 60% in the chest tube drainage alone. Duration was reduced and length of stay was reduced. There is a retrospective review from the United States over, it's like Barnes Jewish, University of Minnesota, SLU, some other big names. Mayo was not included in this retrospective review for some reason. It was like 112 patients they found who they thought could be used for it. Only 75 patients actually underwent valve placement. They showed that the median time to air leak resolution here was 16 days, but look at that range, 2 to 156 days. And then 100% of patients with iatrogenic pneumothorax had resolution with EBV placement with a mean time to air leak of 3 days, but only 58% of patients with SSP had PAL resolution with a mean time to air leak resolution of 15.6 days. So even, I think, if you can't get the leak to stop, this may be an option, but I don't think it should be frontline. So too long didn't listen because I talked so much. This disease is complex, and really this is the art of pulmonary. When managing post-thoracic surgery patients and pneumothoraces, you will absolutely see this disease process. You're going to see it, and you have to be prepared. Your first step, like we saw in the case, should be troubleshoot the chest tube, right? If you think there's a persistent leak, make sure the chest tube's actually right before you diagnose someone with a persistent leak. Next step should probably be to involve a thoracic surgeon. This is a lot of times going to lead to a lot of increased morbidity, maybe mortality, load to both. When to do so is relatively unclear. I would personally, after seeing all this data, favor later than earlier if the patient's stable. Conservative management is a valid approach, but you have to be willing to sit on your hands. If your patient is not high risk and conservative management fails, it looks like probably VATS with bloodectomy and pleurodesis is the likely answer. But if your patient is extremely high risk, maybe these alternative approaches of autologous blood pleurodesis or balloon occlusion or endobronchial valves. Evidence is limited right now, but more will be coming out. And then if all else fails or your patient can't handle anything else, a Heimlich valve can get your patient out of the hospital. And honestly, from everything I've seen related to persistent air leak, time is the healer of all. Here's my references. If you guys want to, this is the Mayo released article on this, summarizing everything I just talked about in 2005. That QR code as well as the link. It's written by one of their fellows, and it's honestly really, really, really well done.